morning, you guys. Thanks for coming. My name is Vanessa Beach. I've worked in CST for 7 or 8 years now. You may know me from Vocera calls, such as your patient's battery is about to die, or your patient's pulse ox is full of lies and keeps alarming, make it stop. In addition to that, I'm also a licensed paramedic. I have current ACLS. And for the past several years, we've been having paramedic students from PCC come through our office every summer for us to torture. And so I have practiced on them, and the result is the presentation that you're about to see. It's my thinking that the way that ECG recognition is traditionally taught is actively unhelpful towards understanding what's going on. So my approach is a little bit different. My thinking is that if you understand what's going on in the heart and why, then the more abstract ECG part will follow kind of naturally. So we're going to start really basic and work our way up, and you'll see several concepts kind of come up again and again as we go through. I really like questions. I prefer the Socratic method, but obviously it doesn't work with big groups. So if you have questions or comments or anything like that, feel free to speak up and we'll stop and talk about stuff. All right. Is there a remote control? You had it? I saw it in your hand at one point.
No, I'm pausing. How do I pause?
Well, this is going to be difficult.
Oh.
Yay. Thank you. Right, here we go. So, the first thing that you need to know is that humans are terrifying tentacle monsters. And that we drive our terrifying tentacle monsters around in suits made of meat. And that the meat is, when you get right down to it, mostly just an extremely complicated system of tubes. A great deal of those tubes are for circulating blood, which is the delivery mechanism for oxygen, which is essential for cellular respiration. So at the center of the blood tube system is the pump, which is the heart. The heart is actually 2 pumps working in parallel. We have our left heart, which delivers oxygenated blood to our tissues, and we have our right heart, which delivers deoxygenated blood to the lungs. And the two just kind of take along, working side by side, and never quite meeting. It's very romantic. Traditionally, when you see the label diagram of the heart, it's very complicated, and there's lots of labels, and there's usually a bunch of arrows too. We're going to make it slightly simpler. So we have in our heart, blood enters the heart through the great vessels, and it enters into the atria. Atrium is a Latin word that means entrance chamber, and that's pretty much just what the atria are. They're thinly walled chambers, and their main job is basically to say, hi, welcome to the heart, we hope you enjoy your stay. And then once everybody's gathered in the atria give a squish, and they send blood through the valves and into the ventricles. The ventricles are the major bit of the heart. They are more thickly muscled. Ventricle is actually a Latin word that means little belly. And once the blood is fully gathered in the ventricles and everybody's got their seatbelts on and everything, the ventricles give a big squish and they send the blood out through the other valves and then out through the great vessels to their respective destinations. That's pretty much it. Blood comes in, blood goes down, blood goes out. So, like most pumps, the heart runs on electricity. The heart is wired with a system of electrical conduction pathways. So we start out up here at the SA node, the sinoatrial node. It's the major pacemaker for the heart. It's a little clump of cells that is responsible for setting up the heartbeat. It sends out the signal that tells the heart how fast to go, and the rest of the heart follows along from there. So once the signal leaves the SA node, it goes diffusely through the atrial tissue and reconvenes down here at the AV node. The atrioventricular node is conveniently centrally located between the two atria on the interventricular septum and between the atria and the ventricles, top to bottom. The job of the AV node is to gather those various diffuse signals together, to coalesce them into one, to slow the signal down a little bit, and then transmit the one coordinated signal down into the bundle branches, the bundle of His out into the bundle branches, and then out through the ventricular tissue on the Purkinje fibers. And that's basically how it goes. Hopefully this is mostly review for most of you. Does anyone have any questions so far? All right, we'll come back to all of it. So, an ECG is a graphical representation of electrical activity in the heart. It doesn't actually tell us anything about muscle at all. Most of the time we're just assuming that the muscle is following along. And here we see a 12 lead, which is intimidatingly complicated. But it's really just 12 different views of the same muscle activity. It's basically 12 different camera angles of the same thing happening. And the different leads can tell us different things about what's going on in different parts of the heart. Most of the time when we look at an ECG, we're looking at lead 2, and then our secondary lead is often lead B2. That one gives us the most traditional angle, or looking, at the heart from the angle that makes the most sense. So, if you remember back to high school algebra, those XY graphs, this is the same deal. An ECG is a graph of electrical activity over time. So if you superimpose that over your graph paper, you have this. And for scale, the traditional scale gives us 1 second is 5 big boxes. Then that follows that 1 big box is 1/5 of a second, or 0.2. And 1 little box is 0.04 seconds. And then on our y-axis, we have 2 big boxes is 1 millivolt. You don't necessarily have to have this part memorized, but it's handy to know, and it's easy to look up if you need it. So it follows that we have time on the x-axis here. So if something, when you're looking at your ECG page, as you go from left to right, you're moving forward in time. And it follows then that if something is wider on your graph, that means it took longer to happen. Does that make sense? Okay, so we have this handy GIF, which I'm still not sure if it's not more confusing than it needs to be, but you can see the red lines following the electrical activity through the heart is mirrored in real time by the ECG on the page. So let's take a look at that in more detail. This right here is your standard single cardiac cycle. You'll see there are 3 bumps, or 2 bumps and a squiggle, depending. And those bumps are labeled in alphabetical order, because why not? It's very convenient that way. The first bump, the P wave, represents atrial depolarization. So that is to say that the cells of the atria are depolarizing, they're squishing, and theoretically the muscle of the atria is then contracting. And then we have the big squiggle, which is called the QRS complex. Even if it doesn't have all of the named waves, we still call it the QRS complex. And that is the ventricular depolarization. It's a bigger squiggle on the page because the ventricles are a bigger muscle mass, and they take more electricity. And then we have our third bump, which is the T wave. That is the reset button. The T wave represents the cells of the ventricles resetting. All the electrolytes are rushing back over their membranes and what have you, so that by the end of the T wave, all of the cells of your heart are ready to go again. So, I said this was the single unit of a cardiac cycle. You're not always going to see every single thing on this diagram in everybody's rhythm. Not everybody has a P wave, for example. You can't always see a T wave. The QRS part is the mandatory part. If you don't have your QRS complex, things have gone badly wrong. But the other 2 are kind of optional. Now that is not to say that if you can't see the T wave, it's not there. What would happen if your ventricles didn't repolarize, if there truly wasn't a T wave in somebody's rhythm? What would that look like? Any ideas?
You mean what rhythm would they be having?
Kind of, yeah. I mean, how would that present clinically?
SVT maybe?
Maybe. The simple answer is that if your patient's ventricles are truly not repolarizing and you don't actually have a T wave going on, your patient would be dead.
Yeah.
That's how you would tell. If they are dead, their ventricles are not repolarizing. So, let's move on to the actual rhythm itself. Sinus rhythm. This one is the default rhythm. It comes factory installed for most people. It's very popular. As we discussed earlier, in sinus rhythm, all the waves are in alphabetical order. In lead 2, which I said is the lead you're going to be looking at most of the time, the P wave and the QRS complex are both going to be upright. That is to say they're going to be above the isoelectric line most of the time. The intrinsic rate of sinus rhythm is 60 to 100 beats per minute. That is the normal rate range that your SA node kicks off on automatically. Of course, you know, that depends, varying on, depending on cardiac demand and stuff like that. But 60 to 100 is considered normal. And then we have some measurements because we're nerds and we really like to measure stuff. So, our PR interval, which is the distance between the beginning of the P wave and the beginning of the QRS complex, ideally would be between 0.12, which is 3 small boxes, and 0.20, which is 1 big box or 5 small boxes. Our QRS interval, which is the length of time that the ventricles take to depolarize, so beginning of QRS to end of complex, is ideally less than 0.12 seconds or 3 small boxes. And then our QT interval, which is a uncommonly discussed interval, it's the beginning of the QRS complex to the end of the T wave, is usually anything less than a half second is considered okay for QT intervals. It really helps to have those numbers memorized, but again, it's easy to look them up, so it's no big deal if you don't. Does anyone have any questions about sinus rhythm? Well, I have a thing. Pet peeve. Normal sinus rhythm is what most of the people will see, like when you document in Health Connect, it shows up in the textbooks. Normal sinus rhythm is a phrase that rolls off the tongue. I hate it. We don't use it in CST, and here's why. Normal sinus rhythm in clinical terms is describing a rhythm that is not unusual in any way, which is to say that its rate is between 60 and 100. All of the measurements are within normal limits. They're not doing any arrhythmia, they're not irregular at all, they're not having any ectopy, nothing is weird at all. And how many of us can say that about our heart rhythms? None of us. That's how many of us. So in CST, we try not to judge. We just call everybody sinus rhythm and leave it at that. I understand that for Health Connect purposes, you kind of have to use the normal part. So go ahead and use it, just know in your heart that they're wrong and you could do better. All right, let's move on. So, hearts are important. If your heart doesn't work very well, the rest of you isn't going to work very well either. So, like other essential systems in your body, this one has backup systems installed. I said earlier that the SA node is your primary pacemaker, and that's true. But if something goes wrong, then you have your AV node as well ready to take over as backup pacemaker. And if the AV node fails, pretty much anywhere else in the heart will take over as emergency backup pacemaker if necessary. If you remember back to A&P, they talked about cardiac anatomy for what, like 20 minutes one day? And one of the main things that they always talk about in A&P for cardiology is the 3 main characteristics of cardiac cells. They are contractivity, they squeeze; conductivity, they transmit electricity through the pathways; and the third one is the most important here, automaticity. That's the idea that a single myocardial cell, in isolation in a petri dish, if you bathe it in enough epinephrine, will try to set up a rhythm on its own, which is super cool. And here's why. It's because your heart's whole job is to keep blood flowing through your body. So it has to keep beating no matter what. And every single one of those cells will try to set up a rhythm if it can. That's the emergency backup system in action. So let's talk about some of those emergency backup rhythms. We're going to start with the junctional rhythm. The emergency backup rhythm number 1 is initiated by the atrioventricular node, or the AV junction, so we call it the junctional rhythm. Because the junction is not intended to be a primary pacemaker, it's not as good at that job. It's got other things it's good at. So its heart rate is going to be slower. An intrinsic heart rate for a junctional rhythm is usually between 40 to 60 beats per minute. And it's going to look kind of weird on an ECG. It's somewhat difficult to identify a junctional rhythm just by looking because there's a couple different times. It tends to be one of those rhythms where you want several smaller pieces of circumstantial evidence to build a case that you're looking at junctional rhythm. And if you've ruled out all the other possibilities, a lot of times junctional is what you're left with. So, what does that look like? Well, you may have an absent P wave. That's nice and obvious for you. The P wave may be inverted in leads 2, 3, and AVF. It may also be retrograde, which is to say behind the QRS complex, where it's not doing anyone any good at all. And then, of course, you may see a P wave that looks normal, except for the fact that it's way too close to the front of that QRS complex. And for math purposes, way too close means less than 3 small boxes, or 0.12 seconds. And then you may have a QRS complex that is wide and you may not, depending. Yeah, it's a little confusing, but we'll come back to it. Does anyone have any questions about junctional rhythm at this point? All right, so we'll move on. If the junction fails, then we go on to our emergency backup pacemaker, which is the ventricular rhythm. That is basically anything south, anything below the AV node is considered a ventricular rhythm. It's a pretty wide catch-all term. You're going to recognize a ventricular rhythm because it's going to be really slow. The cells of the ventricles are not designed to be primary pacemakers, obviously, and they're bad at it. So a ventricular rhythm is usually going to be between 20 to 40 beats per minute. You're also going to recognize a ventricular rhythm because it's going to look terrible. Look at these. They're horrible. They're big and flabby. They don't look anything at all like the nice, narrow QRS complexes you're used to seeing. You're not really going to see a P wave worth it all because, like I said, the reason that we have a ventricular rhythm is our SA node has failed. And then, of course, you will also recognize a junctional rhythm because your patient will look terrible too. And we'll call you and tell you about it. We'll be very excited. The reason that QRS complexes are wide and bizarre when it comes to ventricular rhythms is because the electricity is not traveling through the tissue along those nice, speedy superhighways that we saw in an earlier diagram. The electricity is traveling through the tissue any way it can. It's diffusing from cell to cell to cell, like a word-of-mouth type of thing. And so it takes a lot longer, and it's following a non-standard path through the tissue, which is why, in a graph of electricity versus time, something that takes longer to happen means wider on the strip. Does that make sense? That's how you're going to recognize a ventricular rhythm. Anyone have any questions about those? Most people don't stay in a ventricular rhythm for very long. They'll usually try to convert to something else pretty quickly. Okay, so we'll talk about ectopy. Most people are doing one of the aforementioned rhythms or something else, and then every once in a while they'll have something weird crop up, just one or a couple beats here and there. So we call those ectopy, which is from a Latin term that literally means from someplace else. And so when we're talking about ectopy, we want to know 3 things. We want to know what kind of ectopy it is, we want to know where it's coming from, and we want to know same, shape, or different. So let's start with what type. We have 2 types of ectopy. We have early beats and we have late ones. Both of these are compensatory mechanisms. Like I said, your heart is important and its job is important, and so it's got a lot of backup systems built in, and this is one of them. Your body has seeded throughout it lots of little sensor cells whose job it is to monitor your system and notice if something starts to get out of whack. So you have chemoreceptors and baroreceptors and all kinds of other receptors. And those cells are going to start to notice if your cardiac output is insufficient to demand. And they'll start to say, hey, we could use a boost here. And that's where premature beats come in. Those are meant to just goose your system along, give a little temporary boost to your cardiac output so that you're better at meeting your own demands. Those are helpful. It used to be, back in the day, we thought that PVCs were bad because they were evidence of cardiac irritability and things could go wrong and we have to stop the PVCs. So we would give a patient who had a lot of PVCs lidocaine to literally anesthetize the heart into stopping having these extra beats. And then we figured out eventually that if you have a patient who's in ventricular bigeminy at 60 beats per minute and you give them a bunch of lidocaine, you take away their PVCs, now they're doing sinus brady at 30 and that's worse. So nowadays we mostly just let the PVCs do what they want because they're there on purpose to help us keep up our homeostasis. And then we have late beats, which we call escape beats. As you can see here, this person is doing a nice sinus rhythm, and then all of a sudden, there's a bit of nothing going on. And you can imagine, if you will, that the ventricles are sitting down there and they're ready to go, and they're waiting for the signal to come from the atrium. They're like, okay, we're ready. Uh-oh, this seems like a long pause. Oh crap, go! And they throw out a beat there. That's called an escape beat, and the reason they're called escape beats is they help you escape from death. Because if this escape beat weren't here, what would we have instead? We'd have asystole, which is not super good. So that's what escape beats are. They are your emergency backup pacemakers kicking in to prevent a loss of circulation, which is, that's the whole point, right? The other thing we want to know about ectopy is where it comes from. So we talked about the 3 major rhythms of the heart, and so we can have ectopy, ectopic beats, come from any of those 3 places. And they follow the same rules as the rhythms that they come from. So ventricular ectopy looks ventricular, which is to say that a single ventricular beat will look just like a ventricular rhythm in that its QRS complex is going to be wide and bizarre. And yes, I definitely picked strips that had the same type of shape, but ventricular ectopy is to paraphrase, you know it when you see it. It's big and gross looking. It's pretty obvious to pick out a ventricular beat. And then atrial ectopy looks atrial, which is to say that we have here a patient in sinus rhythm with PACs. This beat right here and this beat right here are our PACs. And if you notice, they look just like all their friends. They have a nice narrow QRS complex that's the same shape as all the others. They have P waves in front of them, the same as all the others. They just generally look exactly like the other beats. The only way you can tell that they're not is because they don't fit the pattern. They're early. That's PACs. The way that I tell students to recognize PACs is that PACs are like serial killers. They look just like everybody else. And then of course we have junctional ectopy, which looks like not the other things, which is to say that PJCs might have no P waves at all, like these guys here. They may have an inverted P wave, they may have a retrograde or a really close P interval. If you've ruled out the other 2, if you've ruled out the big obvious ventricular beats, and if you've ruled out the look like just like everybody else, serial killers, then what you have remaining is probably junctional. Does anyone have any questions about that part? And then the third thing I said we want to know about ectopy is same shape or different. There you go, serial killers. I had to learn how to make names for this slideshow. I'm all grateful. So same shape or different. When we have a patient throwing a bunch of different ectopy, we want to know same shape or different because that tells us more about what's going on in the heart. So if we have PVCs, for example, that look the same as each other, we're assuming they're coming from a single ectopic focus in the heart. And that's because the electricity is traveling through the tissue following the same pathway, so we can assume that it came from the same place. Then of course if you have multiple ectopic foci, then that electricity for each of those beats is traveling along different pathways, and that's going to give you different shapes on your ECG. So if you have one ectopic focus, we call them unifocal. And if you have multiple ectopic foci, we call them multifocal. Which one is worse, unifocal or multifocal? Huh? Say it louder. Good job, yes. Why is that?
Well, it would seem like it's wearing out the heart a little faster or something. I don't know.
More irritation, yes. The more multifocal PVCs you have, that tells you the more spots of irritability you have in your heart and the more probability there is that something will go wrong. We don't like it when stuff goes wrong. But what if something does go wrong? So we've covered the main rhythm and we've covered the emergency backup rhythms. Now we're going to talk about dysrhythmias. We're going to start with this one. Supraventricular tachycardia, which is hard to say, so we usually just call it SVT. Supraventricular tachycardia is an umbrella term for narrow complex tachycardias. To be an SVT, you have to have a narrow QRS complex and you have to be faster than 150 beats per minute, and that's it. There are several more specific rhythms that qualify as SVT, but it's often difficult to tell the difference between them because it's fast. So SVT is a correct term for any of them. You're going to recognize SVT because it's going to be really fast, like I said. The complexes are going to be narrow, and it's going to be pretty regular because the faster you go, the harder it is to be irregular, if that makes sense. So, re-entry tachycardia. This is an important concept. Basically, the idea is that you have your signal starting in your SA node as normal, and it travels through the tissue of your atria as normal, and then instead of going on out down into your AV node the way it's supposed to, some of that signal gets swept up and back around up into the atrial tissue and circles around again. It's like getting stuck in a revolving door or getting on a traffic circle and forgetting which exit you're supposed to take and just going around and around and around. It's a feedback loop. And so unfortunately, the rest of the heart kind of gets swept up in this, and you wind up just in this really horrible re-entry tachycardia. Does that make sense? The idea of a re-entry tachycardia? We'll come back to it. It's a concept that will appear again. And of course, tachycardia is bad. Why is tachycardia bad? Why do we care if somebody goes fast?
No time to lower the cardiac.
All of those things, yes. So the most obvious problem with the tachycardia is decreased cardiac output, right? You have less ventricular filling time. When the ventricles beat, they're not as full of blood as they could be, and that decreases your blood pressure, and then you're not doing so well perfusing your tissues, and we worry about things like that. But it's not the main reason that we in CST at least care about tachycardia. And the reason that we care about tachycardia is because your heart is made of meat. That is to say, hearts are made of muscle. And what happens if you exercise a muscle really hard and really fast for a really long time? It gets tired, yeah. Your muscle starts to burn, there's some lactic acid buildup, it doesn't work as well as it used to, and then eventually, if you keep working it anyway, it's going to stop doing what its job is altogether, which is bad. So, cardiac, your heart is a muscle, and where in its cardiac cycle, let's go back to this one, where in this cardiac cycle do you suppose that the cardiac tissue itself is being perfused? What do you think? Yeah, where does your heart tissue get its blood flow? Where in this cycle? Yeah. So one cycle is of course one of these guys. And it's a fluid system. So a cardiac cycle has moments of high pressure and moments of low pressure. Your highest pressure moment in that cycle is going to be the QRS complex when the ventricles are really squeezing hard. And that's too high pressure for the heart muscle itself to perfuse. So the heart muscle has to wait for diastole before it can get its blood flow. It has to wait for this little flat spot in between each beat. That's when your coronary arteries have their maximum blood flow. And that's where your cardiac tissue is getting its oxygenation. The diastole is there on purpose. So what happens if you have a rhythm like that? Where is your coronary perfusion happening in this rhythm here? It's really not. Your heart's not perfusing very well at all because it has to try to fit all its blood flow into that tiny little spot between QRS complexes. And it doesn't do so well. And so if you do tachycardia long enough, your heart will eventually start to get ischemic. And then after it gets ischemic enough, it will eventually become infarcted, and then you will have problems. That's why we care about tachycardia. Does anyone have any questions about that? All right, so let's move on. Atrial flutter is the same rhythm, except in this patient, their AV node is doing its job. That is to say that a patient in A flutter is having a reentry tachycardia in their atria, just like an SVT patient is. Except this person's AV node is getting all these signals coming down from the atria, and it's going, whoa, hold on, that's way too many of you. You can't all go through. That's part of its job. And so as a result, a patient in A flutter will have a very fast atrial rate. It's usually above 200 beats per minute. And then your ventricular rate will be less than that. It's usually some kind of fraction. Instead of P waves, yeah, there are flutter waves, which they're technically just P waves, but they're kind of connected together and they look a bit sawtoothy most of the time. And because the AV node is having to decide which of these P waves to conduct, you may have a very fast heart rate. You may have a 2-to-1 ratio of your P waves to QRS complexes. Or you may have a slower one. It's also not necessarily going to be a very regular rhythm. A lot of patients in A flutter are going to be doing some kind of ratio, 3-to-1, 4-to-1, and so on. But not all of them are. Some patients in A flutter are very irregular as well. It really depends. Does anyone have any questions about A flutter? So we'll move on to atrial flutter's cousin, which is atrial fib. Atrial fib is a very popular rhythm. Especially as you get older, a lot of people decide that AFib is the rhythm for them. In AFib, you have your atria, instead of depolarizing in a normal organized fashion to squish that blood down into the ventricles, it's every cell for itself, and they're just sitting there quivering all the time. basically, on an ECG, what that will look like is that you will have no P waves. This part is key, no P waves. Instead, you will also have no visible isoelectric line because your atrial cells are never stopping. They're always, something's always going on in your atria in a patient in AFib. And you're also going to see squiggly fibrillatory waves. So if you can imagine, this person's AV node is very confused. It's getting a whole bunch of random signals, and none of them are the nice clear P wave signals they're used to receiving. And this AV node has to decide which of these signals to send through. It guesses. It does the best it can. And so a patient in AFib is going to have a very irregular ventricular rate. The textbooks will describe this as irregularly irregular, but that's really hard to say, so I don't like it. I prefer globally irregular. Globally irregular is basically if you're looking at an ECG and you want to point to the irregular bit, you basically have to go, that is the irregular bit. The whole thing. There's no discernible pattern. And of course, the opposite to globally irregular would be event-specific irregularity. If you're looking at an ECG and you can point to the thing that's causing the pattern disruption, then you have event-specific irregularity. Does that make sense? So an AFib patient is going to be globally irregular. There's not going to be any noticeable pattern to their QRS complexes. And of course, AFib can be very fast if it wants to, and this can be bad, and we've already talked about why. And then of course, the other thing that we have to worry about in patients in AFib is that, well, they've lost their atrial kick because the atria aren't squeezing to send that blood down into the ventricles for that last little bit of cardiac output. But also, some of that blood, instead of going on through to the ventricles the way it's supposed to, just kind of hangs down in the atria. It's like, yeah, this is cool. And then eventually, if you hang out in the atria long enough, your blood is going to get a little bit jellified and then form some clots, and then those will go wandering off to the body, and that can also cause problems too. Anyone have any questions about AFib? Very popular. Not uncommon. Okay, so ventricular tachycardia is the same idea as A-flutter and SVT. It's a reentry tachycardia. Except in this case, instead of having a reentry tachycardia in the atria, where it's not really harming anybody, this person's reentry tachycardia is in the ventricles, where it's a very bad idea. So again, that signal, it goes on down the bundles, and then out through the Purkinje fibers the way it's supposed to, and then instead of that signal dying, it somehow gets swept around and loops down through the septum and down into the bundles again and out around, just like in SVT. So we have our reentry tachycardia. As the name may imply, that implies that the heart rate is greater than 100, and this is a rule. If your heart rate is greater than 100, you get to call it tachycardia no matter what kind of rhythm it is. It's very helpful. You're going to recognize it on an ECG because the QRS complexes will be wide and bizarre. Just like in ventricular ectopy and a ventricular rhythm, this is a ventricular rhythm, so the same rules apply. QRS complexes are going to be wide and they're going to look terrible. This is more difficult for your heart to do because these QRS complexes are less efficient than the nice narrow ones that we usually see. The heart has to work harder when it has its signal dispersing this way. And so this person is going to become even more hypoxic even faster. You can sustain, you can live in VTAC for maybe a couple minutes if you're lucky. And then your heart is going to get tired faster, and then you're going to convert to a different rhythm. And then of course, unifocal VTAC is going to have same shape complexes. That is to say, everything's going to look very samey, and it's going to be very regular in heart rate. And then, if, like I said earlier, same shape and different, we also have different shape VTAC, which is this one. You can see here that the complexes get big and then small, and then big and then small. We call this torsades de pointe. It's the most common form of multifocal VTAC, which is French for twisting of the points because it kind of looks like the Reuben is twisting. It looks really cool, but it's not actually any better for you than the other kind of VTAC. Looks cool. You want to help this patient with electrical therapy, usually, and that's what this is. On the strip here, you see the big up and down line, and then it flattens out at the top. Hearts are not actually all that big. They're about the size of your clenched fist, and so the amount of electricity that goes through them is kind of tiny. If you have a large amount of electricity that's introduced on that same scale graph, it's going to go off the charts, and this is a shock. That's what a shock looks like on an ECG. Ideally, after the shock, you would see a nice little stretch of asystole, which apparently did not happen in this case. The idea of a shock is that you want to induce asystole. The asystole after a shock is there so that your heart can go, okay, it brings it out of the feedback loop, brings it out of whatever reentry tachycardia it's in. And it's the chance for one of the intrinsic pacemakers to kick in. So you want to stop the bad rhythm and let the SA node or something else take over and reinstate some kind of normal rhythm. That's the idea behind a shock, but as here, it doesn't always work. Does anyone have any questions about VTach or torsades? So, I said that you're not going to be able to sustain a rhythm like this for very long, a couple minutes maybe if you're lucky, and then you're going to convert into a different rhythm. And the rhythm that you're going to convert into is this one. This is a bad rhythm. It's the same basic idea as AFib, except instead of fibrillating in the atria where nothing can really happen badly, this person's ventricles are fibrillating, which is not super ideal because that means they're not circulating any blood. A ventricle that is just sitting there and quivering instead of squishing blood around is not doing its job, and you will recognize a patient in VFib because they will be dead. This person does not have a pulse. Your fibrillatory waves, basic same idea there as the AFib patient, except this patient obviously doesn't have QRS complexes. Your fibrillatory waves will be big or they can be small depending on how long they've been fibrillating. Does anyone have any questions about VFib? So if you have been VTaching for a while and then your heart gets tired and oxygen hungry and then you do some fibrillation for a while and nothing happens to help you get into a better rhythm, you're eventually going to convert into a more stable rhythm on your own. And the more stable rhythm that you will convert into is this one. This is a very stable rhythm. You will stay in it for the rest of your life. Asystole, the name, specifically refers to the lack of systole, the lack of high pressure moments in your cardiac cycle. This person is not having any blood pressure at all. And more specifically, they're not having any QRS complexes. You can have a patient who is in asystole and has P waves. Their atria are trying really hard and they're doing a very commendable job, but it's not helping at all because your atria cannot circulate blood on their own. So you can have a patient in asystole with P waves, that still counts as asystole. Does anyone have any questions about asystole? All right. So, what about if something goes weird? So we talked about the main rhythm, we've talked about the emergency backup rhythms, and we've talked about the dysrhythmias. Now we're going to talk about all the other stuff that doesn't fit into any of those categories. And we're going to start with bonobranch blocks. Bonobranch block, when you get right down to it, is simply a widened QRS complex. Any QRS complex that is wider than 0.12 seconds, or 3 small boxes, counts as a bonobranch block. All that means is that there's some kind of conduction delay in your heart's electrical system. So you can see here in this diagram that the electricity signals are passing through the atria the way they're supposed to, and then down into the AV node. And then right here in one of this patient's bundles, there's a problem. And the electricity cannot get through in its normal pathways. So that electricity, basically, if you think of the electrical pathways as superhighways, the electricity is driving on down its highway, and then there's a wreck, or some construction, or a tree falling on the road, or something like that. And the electricity has to take the exit, and then sit at the traffic light, and then turn left, and then drive through the school zone, and then wait for the pedestrians to cross, and then take the other traffic light. And then it eventually gets back onto that superhighway, but it takes longer. And because that this is a graph of electrical activity over time, takes longer equals wider. If you look at a patient with a bonobranch block in a 12 lead, like I said, those 12 different angles will tell you different things about where their particular conduction delay is located. The easy way to tell if you should be worried about what kind of bonobranch block your patient has, whether it's a hemi block or a fascicular block or blah, 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 is to look at your paycheck. If you make a lot of money, you should probably worry about stuff like that. If you don't make a lot of money, then the patient has a bonobranch block is okay. We can leave it at that. In our office, we do not differentiate between the two. We simply know that the patient has a widened QRS complex, and we document that as whatever their rhythm is with a monobranch block. If you guys want to, I know that when you document on Health Connect, it asks you to specify left versus right monobranch block. You can call us and ask us. We will pull up a 12 lead for that particular patient and look at lead V1, which is the one you need to look at, and then we'll, tell you left versus right. Or, as I understand it, you can document their underlying rhythm, whatever it is, and then add a comment to that, and just say that, their patient is in AFib with a monobranch block. Apparently that should work too. Monobranch blocks are really common. There's a bunch of different reasons you can have a monobranch block. You can have one due to ischemia or infarct or a congenital abnormality or an old surgical scar, or I'm sure there are some medications that can cause prolonged conduction delays.
Sorry.
Monobranch blocks are really common. A lot of people who are not very experienced at looking at ECGs kind of fall into the trap of thinking that all wide QRS complexes equals ventricular rhythm. That's not the case. By far, the most common reason for a wide QRS complex is the patient has a monobranch block. And that's okay. We don't really treat them. We just note them as an adjectival addendum to their underlying rhythm and leave it at that. Does anyone have any questions about monobranch blocks?
So sometimes you're called from CST. Is it just when they first notice it or something? Is that, you're saying it doesn't really necessarily matter, but
Yeah.
it's usually noted, or I've been
Yeah.
called before? Is that just when it first shows up, or somebody notices, or what?
Generally, if they came in with a monobranch block, we're not going to make a big deal about it. The reasons that we would call you about a bundle are usually because it's changed in some fashion. That's what concerns us, if stuff is different than it used to be. So some patients have a couple different conduction pathways that their electricity will follow depending on the phase of the moon or what mood they're in or who knows what. And so some of those patients will have a rhythm where their QRS complex changes shape from time to time, and that concerns us. We'll call you and tell you about that usually. Or if a patient didn't have a bundle when they came in, and then all of a sudden their QRS is wider than it used to be, we'll call you about that too, because that may be evidence that something upsetting is going on. But yeah, most of the time we just note it and move on. Any other questions? All right. Let's talk about AV blocks. AV blocks are not that bad either. All that AV blocks imply is that there is something wrong with conduction through your AV node. Do you guys have questions? Is there something I can help you with?
She's telling us to shh.
They need to be separated.
All right, so the AV node, I mentioned earlier, the job of the AV node is to coordinate and coalesce the signals coming from the atria, to slow down that signal and then pass it on through the ventricles. That is a fairly complicated system of jobs that little bundle of cells has to do, and sometimes stuff goes wrong. And so things can go wrong in a couple different ways, and we classify AV blocks based on that. So let's start out with a first-degree AV block. AV first-degree blocks are very common. Lots of people have them, and that's okay. All a first-degree block means is that conduction through the AV node is slowed, and that gives us a longer PR interval. You may remember, of course, that a PR interval is supposed to be less than one big box or 5 small boxes, and this one is more than that. So basically you have your blood leaving the atria and rushing through into the ventricles, and then the blood sits there and it's like ready to go. Anytime now? Oh, there we go. Slightly longer pause than normal. That's okay. We would note it and move on. And it's worth noting that a first-degree block is not really considered a rhythm in its own right. It's an adjective more than anything, so we would always document this as sinus rhythm with a first-degree AV block. Anyone have any questions about AV first-degree blocks? They're cool. Lots of people have them. Second-degree blocks, on the other hand, are characterized by missing beats. That's the idea that the conduction through the AV node is starting to fail altogether, and sometimes those signals don't get through at all. There are two main types of second-degree block. The first one is the slow fade. So here we have a QRS complex that's following after its P wave in a normal amount of time. And then consecutive beats have slightly longer PR intervals, longer and longer, and then all of a sudden, no QRS complex at all. We call this a second degree type 1 or a Winkie-Bach. Winkie-Bach is difficult to spell, so we in our office often just use the second degree type 1. Winkie-Bachs are fairly common. They're not common per se, but they are the more common of the second degree blocks. You're most likely to see this one in the wild. It's actually pretty easy to recognize a second degree type 1 because human brains are great at recognizing patterns. And so you can kind of eyeball this and you're like, there's some beats missing. And you can take your missing beat there and you can take a look at the PR interval immediately after it. And then you can compare that to the PR interval immediately before the missing beat. That should be your biggest difference, and that will make it most obvious that the kind of block we're looking at is a second degree type 1. Danielle has a rhyme that she likes to tell.
Well, so the way that I remember it is it's longer, longer, longer drop, then you've got a Winkie-Bach. And in order to know that it's a type 1, you remember that you wink with one eye, right? Second degree type 1. There you go.
Does anyone have any questions about Winkie-Bachs? All right, then we'll go into the second type, which is the total ghost. So in a block of this type, you will see a PR interval that is fairly normal looking. And then consecutive beats will have also fairly normal looking PR intervals. They'll ideally be the same PR interval every time, until all of a sudden you have no QRS complex at all. So we call this one a second degree type 2 or a Mobitz 2 because of reasons. And it is really rare. You're almost never going to see a true second degree type 2 like this in the wild. I hardly ever have. Almost never sustains. You may see a rhythm like this transiently in moments of extreme vagal pressure. If your patient is vomiting really hard or really straining to go to the bathroom, or you've just pushed some adenosine after that terrifying moment of nothing at all, they will often come back in some kind of AV block like this in a transient fashion before they restore to a normal rhythm, hopefully. But it very rarely sustains. Yeah.
I just had a quick question. For both of these, this is their regular rhythm, so it wouldn't just be like happening sporadically. It would be like longer, longer, longer drop, longer, longer, longer drop.
Yeah.
Like continuously. Okay.
And of course that depends per patient. Sometimes they'll have, a few seconds between drop beats. Sometimes they'll have like a minute or more, but it will be a pattern that repeats frequently enough for us for you to recognize it. Just one or two drop beats like this does not by itself qualify as a second degree.
And this is if they're in this, they're always in this. This is a normal rhythm for them.
For that moment of time, yeah.
Okay.
Which, maybe a couple days or a couple of hours.
Oh, so they can go out and back into a regular.
Yeah, we don't want a patient to stay in a second degree for very long. Usually because if they're left to their own devices for long enough, they'll convert to something less stable.
Mm-hmm.
We would ideally like to treat the underlying problem.
And the same is true of a first degree block?
No, first degree blocks are usually fairly innocuous. And the basic rule of thumb with any of this cardiology stuff is look at the patient. If your patient is perfusing and mentating and oxygenating adequately, we are totally fine with whatever rhythm they're in, at least for the short term. So, if your patient is okay with their heart rhythm, so are we. That's great. Keep moving the blood, buddy. And then obviously if something is kind of weird about their rhythm, we want to treat those underlying causes, but so long as the patient is perfusing adequately, it's good enough for us. Does that help? Yeah. And then there's a third type of second degree, because I lied. Third type doesn't fit into either of the other two categories. You'll notice that when we talk about type 1 and type 2 second degrees, what we're talking about is PR intervals. We're comparing PR intervals to each other in order to classify those second degrees. But this patient doesn't have two PR intervals in a row. Every PR interval is number 1 in the sequence because every other beat is dropped. So we can't tell if this patient's PR interval is getting longer or not because there aren't two next to each other. So this one we call a second degree AV block with 2-to-1 conduction because that's as far as we can go. A lot of textbooks will describe this as a second degree type 2, but they are wrong. because we are doing science, this is evidence-based medicine, and we do not have enough evidence to say whether this is a type 1 or a type 2 or not. So we're just going to stop at second degree with 2-to-1 conduction. I have never had a doctor push back on that description. They're all going to understand what you mean, and if they don't, send it to us and we'll yell at them. Or calmly explain what we're talking about, one of the two. So this is a totally okay description because, like I said, this is science, and if you're describing what you see, you really can't go very far wrong. Of course, you can also have different ratios there. It's not uncommon, not impossible to see a patient in a second degree with a 3-to-1 or a 4-to-1 and so on and so forth, but those patients tend to have bigger problems. But this is not an uncommon rhythm. You're going to see this rhythm a lot more than you're going to see a true type 2. Patients tend to drop every other beat, not too rarely. Does anyone have any questions about the 2-to-1 conductions?
That's not a very good perfusion rate though, is it?
It depends on the ventricular rate. Yeah, this
Right.
one's pretty brainy.
Yeah.
But yeah, it's possible to have a patient in a 2-to-1 conduction that is slightly faster than that. And if they feel okay, then we have some time to figure out what's wrong and try to fix it. Yeah, the problems with any of the second or third degrees is usually going to be symptomatic bradycardia. And we would treat that with transcutaneous pacing. So, speaking of third degrees, let's go to third degrees. Third degree blocks are often also called complete heart blocks because that's exactly what's going on. There's a total disruption somewhere in that conduction system, and the signal is not getting through at all. So we can see it here in this fuzzy diagram that we have our signal leaving the SA node as normal, and then it progresses down into the AV node as normal, and then right after it hits the bundle branches, total system breakdown, and the ventricles are left sitting down there, hanging, going, anybody? Hello? Anyone? Oh crap, we better do something. And they kick into an escape rhythm of their own. That's what you're going to see on the ECG. It's 2 rhythms layered on top of each other. This patient has a ventricular escape rhythm going on, and then underneath it, a bunch of P waves ticking along merrily, not doing anything at all. That's going to be your characteristic of a third degree block, is there's not any relationship at all between the P waves and the QRS complexes. Normally, a P wave would be in front of a QRS complex because P waves cause QRS complexes, right? That's the way it's supposed to work. They're chained together. These guys, not connected at all. There's no consistent PR interval. You're going to see P waves in weird places, like there's one here in this T wave. And sometimes you're going to see P waves that are at the same time as a QRS complex, which is not supposed to happen normally at all. Textbook-wise, most of the time when they're talking about third degree blocks, they're talking about rhythms like this. Rhythms that are slow with wide, bizarre complexes from a ventricular escape rhythm, but that doesn't have to happen. If we look at this fuzzy diagram, we see the signal leaving the SA node, and then before it even gets as far as the AV node, there's a total system blockade. So this person's escape rhythm is coming from their AV node. This patient is in a junctional escape rhythm, and their heart rate's significantly faster. And that's okay. That still counts as a third degree block because look at those P waves. They're not doing any good at all. The slam dunk you're definitely looking at a third degree thing to look for in ECGs is a P wave that is coinciding with a QRS complex. That is to say, happening at the same time, because that doesn't happen in any other rhythm at all. And you can see one, there's one right there. QRS complex and a P wave kind of stacked on top of each other like that. That's definitely a third degree thing. In fact, this is a rule across all of the blocks, AV blocks, second and third degree, and heck, even first degree blocks. The rule is that your P waves must be regular. And this is because the SA node doesn't know that anything is wrong. As far as the SA node knows, everything is going along and everybody's doing exactly what they're supposed to do in the right order. There's no feedback loop. The ventricles can't call the SA node on the phone and go, something has gone horribly wrong. So the P waves are just ticking along doing their thing. And you're going to be able to measure them out with calipers or what have you. And you're going to always be able to tell when your P waves happen because they're regular. Even if you can't see them, you would be able to find the P waves. And we can tell with math that there's a P wave hidden in this T wave. We can also tell because the T wave is a different shape, but there you go. And so if you were trying to tell if you're looking at a second or a third degree block, march out your P waves with calipers. It'll make you look really smart if you have a rhythm that looks like a second degree but isn't, because you can tell because your P waves aren't regular. So anybody have any questions about those or third degree blocks in general?
Do we have to do
It helps.
that? Helps what? So does it go, the blocks go 1, 2, 3?
Not necessarily. It depends on the underlying pathology and what's going on.
And like this, would this be something that they would do something about? Like-
Yes.
Oh, yeah.
Yes. Most patients in a third degree block are experiencing some symptomatic bradycardia. They're not usually this fast. And even if they are, we tend to worry about them because what if they slow down later? What if the AV node craps out at a later time? A lot of patients who are living in a third degree block are candidates for pacemaker implantation. It's actually really easy to recognize second and third degree blocks because, like I said, human brains are really great at recognizing patterns. It's like a low down hindbrain survival mechanism for picking out, say, saber-toothed tigers among tall grass. If you take a rhythm like this and you're kind of just looking at it and you're like, something doesn't look right, it's really easy to pick out those patterns if you kind of relax your eyes and just see them. Any other questions about third degree blocks? So there you go, that's the rule about AV blocks in general. P waves are always going to be regular. Okay, let's talk about wandering atrial pacemakers. Wandering atrial pacemakers are my least favorite rhythm. In a wandering atrial pacemaker, we have the same concept of multiple irritable foci that we saw in our multifocal PVCs, except in this case, we have several different clusters of cells in your atria that think they are the SA node. Of course, they're wrong, they're not all the SA node, but they're pretending to be. And so this patient's various irritable foci are sending out signals that are causing P waves. But because those signals are traveling through the cells along variable paths, you're going to get differently shaped P waves as a result. So if you look at this strip right here, this patient has a tall pointy P wave, and then a pretty flat P wave, and then a tall rounded P wave. And this one's got a notch in it, that one's almost not there at all, this one's upside down, etc., etc. A patient in wandering atrial pacemaker is technically a sinus rhythm because they have P waves, but you're going to see it, the textbook says 3 or more different P wave morphologies. And as a result of this, because those various faux SA nodes are not conferring with each other, there's no internal rhythm going on. A patient in a wandering atrial pacemaker is going to be a very irregular heartbeat. It's easy to fall into the trap of irregular equals AFib. Don't do that. There's lots of different reasons your patient's heart rate might be irregular. And this is a great one of them. This patient is going to be super irregular, but they still have P waves, so they're not allowed to be called AFib. You can't be both. So this is a wandering atrial pacemaker. They're not uncommon. I'd say in our CST office at the moment, our average census is about 130 patients at any given time. And of those 130 patients, maybe 2 or 3 will be in a wandering atrial pacemaker. It's something that people just live in sometimes, and that's okay with us. Anyone have any questions about those? All right, let's move on to the other kind of pacemaker, which is to say the artificial ones. These are the little tiny computers that they implant under your skin to send secret rules to your heart. When we talk about artificial pacemakers, there's 3 things that we want to know. We want to know what kind of pacing it is doing, that is to say which part of the heart is getting paced. We want to know how much pacing it's doing, and we want to know whether it's working or not. So, what kind of pacing? Well, when we look at a strip of an ECG for a patient with an artificial pacemaker, you're going to notice pacer spikes. That's your big giveaway right there. Pacer spikes are pretty easy to notice because they're vertical lines. And meat does not make vertical lines. Your heart's made of meat, and like all the other kinds of meat, heart makes curves, makes nice distribution bell curves. Some of them are fairly steep, like this one, but they're not straight lines. And so if you see a series of perfectly vertical straight lines on your ECG, then that's a pretty good sign that your patient may have a pacemaker, or that something has mechanically gone wrong with their wires, or there's outside interference, something like that. So this person has pacemaker spikes in front of their P waves. That is to say the pacemaker is causing the P waves to happen. The electrical stimulus is stimulating the atria to contract, and so we call this atrial pacing. This person has pacer spikes in front of their QRS complexes. This is ventricular pacing. And you will notice when you look at these QRS complexes that they look terrible. They're wide and bizarre, the same way that PVCs are, and that's on purpose. It's because when the doctors implant the pacemaker wires into the cardiac tissue, they don't carefully float them down and gently insert them just so along those conduction pathways. No, they float them in and they jam them into any convenient part of myocardial tissue, and then they wait for scar tissue to form over it and hold it there. That means that the electricity is following a non-standard pathway through the tissue when those pace beats happen, and what you have is essentially an artificial PVC. It's actually a really good sign because if you're looking at a patient with a ventricular pacemaker and their QRS complex doesn't look wide and terrible, then that may be a hint that the pacemaker might not be working the way it's supposed to. And then we have this patient who has pacer spikes in front of their P waves and in front of their QRS complex. This person is atrioventricularly paced. And then, final kind, this patient has all the pacer spikes. They have a pacer spike in front of their P wave and also in front of their two pacer spikes in front of our QRS complex. This patient is biventricularly paced. They have a pacer wire in each ventricle separately. The idea behind that is usually when a patient has some kind of cardiomyopathy where one side of the heart is more enlarged than the other, the side of the heart that's flabby and tired and worn out and not very effective beats slower and circulates its blood more slowly than the nice fit trim side, and so you wind up with a timing mismatch. These pacer wires are there to help even the timing out for a patient with a really uneven heart like that. Currently, as far as I know, that is the most pacing you can have. Okay, so those are the types of pacing. I also said we want to know how much is getting paced. Well, it's easy to tell on this patient. This patient has literally 100% of their cardiac activity is pacemaker induced. But if we take a look at this patient has not 100% of their P waves induced by pacer spikes. So those are your choices. You have 100% paced or not 100% paced. And the term that we use for not 100% paced is demand pacemaking. And like I said, pacemakers have secret rules that they operate by, which maybe you could probably look up on Health Connect or something, but we can't tell. So oftentimes a patient has a demand pacemaker that's heart rate related. So you have a patient that's trundling along in the halls with their walker saying hello to everybody, and their heart rate is ticking along naturally with no pacer activity at all, at like 83 or 102 or something like that. And then they go back to their room and they sit down in their recliner and they watch the news and they start to fall asleep. And their heart rate goes down because their cardiac demand is reduced. And eventually the heart rate is going to fall below that predetermined threshold, which is usually 60. Their heart rate gets to 59 and bam, pacemaker kicks in to keep it exactly at 60 until the heart rate naturally picks up above that. That's most often what you're going to see with a demand pacemaker. And then of course, because the pacemakers are increasingly complicated as time goes on, because that's pretty cool. You may see a patient who is, say, 100% ventricularly paced, but atrially paced only on demand, or vice versa. The computers are becoming more and more sophisticated. So if you have a patient that is not 100% paced, we just call it demand pacing. And then the other thing I said you want to know about pacemakers is whether or not they're working. Well, the most direct way to tell if your pacemaker is working or not is to look at them. Do they look okay? Are they dead? If not, their pacemaker may be working appropriately. Just like the rest of ECGs, this is electrical activity only. It doesn't tell us anything about the muscle activity. So we in CST can't tell at all if these patients are alive. That's part of you guys' thing to do the assessment. On a less obvious note, there's two main kinds of pacer dysfunction. We can have failure to capture and failure to sense. Failure to sense is usually a problem with the computer to recognize when an appropriate time for a pacing is. And what that will look like is you'll have pacer spikes in weird places. You'll have a pacemaker spike, say, sticking out of the T wave, or halfway in and out of the QRS complex, or you have a whole bunch of them in a row. When something like that happens, we'll generally call you up and we'll say, hey, we're seeing weird pacer activity in your patient in room whatever. You may want to get their pacemaker interrogated. We're going to use those may and might type phrases because, like I said, we can't tell what the pacemaker is programmed to do, and some of that stuff that looks weird to us is actually on purpose. But that's you guys. That's the ball's in your court from there. And then the other problem that we may have is a failure to capture. What a failure to capture will look like is you'll see a pacer spike with nothing after it at all, indicating that for whatever reason, the amount of electrical stimulus was not large enough to achieve a muscular contraction. That is generally a problem. And we want to know, basically. We want to know if your patients have pacemakers. We in CST do. And the reason that we want to know is because of this failure to capture thing. We use Philips software that is very sophisticated and cool and can do a lot of stuff. But at its basic level, it's stupid. It's just a computer program, and all it's looking for is vertical deflection off that isoelectric line. It's looking for up and down. And so if the computer doesn't know that the patient has a pacemaker, it doesn't know to filter out those particular vertical deflections. It can't allow for those. And so if you have a patient with a pacemaker and the computer doesn't know about the pacemaker, you might have something like this, and the computer's like, vertical deflection, we're fine, everything's cool. This is failure to capture. But if the patient does have a pacemaker and the computer does know about it, then it will filter out those pacer spikes and go, oh my gosh, asystole, alarm, 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 which is what we want to happen. So that then we can call you and tell you about it very quickly. Does anyone have any questions about artificial pacemakers, stuff like that? So if in the course of your treatment, say you're perusing the chart or talking to the patient or doing a physical exam and you notice, oh, they have a pacemaker, by all means, call us and tell us about it. We'll be very happy to hear that information because we don't have Health Connect and we can't look it up for ourselves. Are we okay there? Good to move on? Yeah. All right. We're getting to the end, guys. RNT phenomenon. Has anybody seen a diagram that looks like this before? It's a fairly common thing in ECG textbooks. So we talked about way back at the beginning about this T wave here, and we said that the T wave is the reset button. The T wave is a nice bell curve that represents the cells of your ventricles repolarizing. They're resetting, they're getting ready to beat again. And so then we have these little shaded areas here. This dark shaded area is called the absolute refractory period. And that is the stretch of time during which no stimulus, no matter how large, can cause your ventricles to beat again. It's simply physically not possible. There is no way your ventricles can squeeze a second time during that time frame. However, this little bit here at the end, from the middle of the T wave onto the end, is called the relative refractory period, and that is your danger zone. The relative refractory period is the short period of time during which a sufficiently large stimulus can cause a second depolarization, which is bad, because a sufficiently large stimulus causing a second repolarization can sometimes look like that. This is the old feedback loop. This is the old re-entry tachycardia again. And basically what's happening there is your myocardial cells are still repolarizing, and like I said, nature, meat, does not make straight lines. It's a bell curve. So most of your cells, by you get to the middle of the T wave, most of the ventricle cells have repolarized and they're ready to go again. And that sufficiently large stimulus comes down the pipe and they're like, okay, and they beat again. But though there are a group of cells that are still stragglers, they're still repolarizing, they're still getting ready to go. And they see all of their friends depolarize. And they're like, oh, we better go. So as soon as they finish getting ready, they depolarize too after their friends do. And then that last little group of stragglers is still putting on their shoes and tying them up and everything. And they see everybody else go, and as soon as they can, they depolarize too. Unfortunately, by the time that last little group of stragglers depolarizes, the very first group is already done repolarizing. And then they see their friends go, and they're like, oh, I guess we're supposed to go again. And then we have a re-entry tachycardia, and that is bad. If you've ever seen or heard a news story about an athlete, say, getting hit in the chest by a baseball and dying, that's exactly the same idea. It's called commotio cordis, and that's what happened. That patient just had the extreme bad luck to be hit with a sufficiently large stimulus at exactly the wrong time, and it sent them into VTAC and they died. We use this concept actually kind of a lot in medicine. It's the reason that we have synchronized cardioversion instead of just straight defib for patients with a pulse. Is because if we don't synchronize with those R waves, and we happen to send that shock in at exactly the wrong time, we can make them worse. It's also the logic behind the precordial thump. If you remember back in the olden days, part of the ACLS protocol used to be someone would go, "Ugh," and then fall over, and then you would say, "You, call the code and grab the cart," and then you'd run up to the patient and you'd punch him in the chest. That same idea in practice. The idea was that if you were very lucky, you could disrupt that feedback loop just the same way a shock would, and you bring them out of their horrible reentry tachycardia. So that's what we talk about. That's why we worry about RNT phenomenon, is because it's vanishingly rare. Everybody's having T waves all over the place, and we're not all dropping dead of ETAC. But when it does happen, the results are bad enough that we worry about it all the time anyway. So, I keep saying sufficiently large stimulus. Does someone have a question? No? I keep saying sufficiently large stimulus. Well, what happens if you have an insufficiently large stimulus during this relative refractory period? Great question. That's what happens if you have an insufficiently large stimulus. You'll notice here that this patient is ticking along in their sinus rhythm, doing pretty good, and then we have a P wave sticking out of the end of that T wave, smack in the middle of the relative refractory period, and nothing happens. There's a nice big pause there. Your heart goes, well, that was awkward, and then it starts its sinus rhythm again. This is because that P wave was not a large enough stimulus to cause the ventricles to depolarize early. This is called a non-conducted PAC, and they're actually really common. People are having non-conducted PACs all the time. It's totally fine. It's actually a really nice red herring for a second-degree block, because they kind of look like second-degree blocks if you don't know what you're looking at. But here's where measuring out your P waves for second-degree block will save you. Because if you measure your P waves, you'll notice that this one is definitely not on time. It's early. You could even say it's premature. And you'll go, that's not a second degree, and it'll make you look really smart. So, those are your RNT phenomenon options. Now, if you remember, way back at the beginning, I talked about QT intervals. You have all obviously remembered that I said a QT interval was supposed to be less than 0.5 seconds. And why is that? Why do we care if your QT interval is longer than that? Anyone? We care because the longer your QT segment is, the larger that relative refractory period is, the bigger the danger zone is. If your QT is prolonged, the more chance there is that something will go horribly wrong. So if you think back to pharmacology class, the list of medications that cause QT prolongation is really long, right? There's a bunch of stuff that you can give that will cause a slowed down repolarization. So if that is something that you're worried about for your patients, you can call us up and you can tell us about it. You can say, hey, this patient's on a whole bunch of amiodarone, or we just gave them some Haldol, or they're starting on Sotalol. Could you monitor their QT segment for us? We can measure it. We measure them anyway all the time as part of our normal measurements. But we can measure them, say, every 4 hours or every 6 hours or however often you want us to know. We can call you if they get longer. We can call you if they cross a certain threshold. The computer actually has a software subroutine that will do that automatically if you want it to. And we will monitor them for you. That is a service that we offer. All you have to do is call and ask. Does anyone have any questions about RNTs? All right. Last thing. Almost made it. ST changes. Your ST segment is this nice little flat bit of isoelectric line between ventricular depolarization and ventricular repolarization. Nothing is going on there. Zero electrical activity, so that's why we have a nice flat isoelectric line on purpose. However, some patients have changes in their cardiac tissue that are reflected in deviations from this isoelectric line in their ST segment. And there's lots of reasons a patient can have ST changes. You can have ST changes because you have a bundle branch block. You can have ST changes because of a medication change, or a congenital anomaly, or an old surgical scar. But of course, the thing that we talk about most when it comes to ST changes is ischemia or infarction. Those are the things that we worry about. However, a lot of the patients that are in the hospital and on telemetry, you may be surprised to hear, are sick. And some of those things are chronic conditions that have nothing to do with the reason they're here. You know, you may have a patient who has an old MI, but they're in for a shoulder surgery. That's okay. And those patients are going to come in with ST changes already. they're looking weird normally. That's how they live now. And that's okay with us. We're not gonna look at ST changes and be worried automatically. What we care about is change over time. So your patient will come into the hospital and will be placed on the monitor. We'll take that beginning baseline admission strip, and the computer will take a snapshot of what their rhythm looks like at that moment, and it will compare every subsequent beat to that first one. And if there's a change that's significant enough, some alarms will go off, and we'll take a look and we'll go, and then we'll call you up and we'll say, hey, I'm seeing some ST changes in leads 2, 3, and AVF. Is your patient experiencing any chest pain? And then you go and you know how you're feeling, and you got a 12 lead if necessary and stuff like that. So we're really only gonna care if these T waves are changing from where they started, if that makes sense. And it also doesn't have anything at all to do with ECG interpretation. A patient can have T wave changes no matter what kind of rhythm they're in. You can have funky STs if you're in AFib, you can have funky STs if you're in sinus or whatever. So we really don't pay attention to the end of that kind of stuff. We mostly look at the front half of a patient's rhythm when we're trying to decide what it is. So we'll note ST changes and then move along. Does that make sense? Anyone have any questions about ST changes? Alrighty, great job. Okay, so I just gave you a bunch of information. ECG interpretation has a really high knowledge threshold, and you've all, of course, remembered it all, filed away with perfect recall. You're good to go, right? Okay, thanks for listening. So I made a thing. This here, Danielle showed you the first version of it, and over the course of all these classes, it has become increasingly complex and more detailed, and I color-coded it and stuff like that. But basically, this is the decision tree that I follow mentally every time I try to identify an ECG. You start out at the really basic questions up at the top, and you follow them on down until you get to what your patient's doing. And we're going to take a break, and then we're going to come back and we're going to practice using the algorithm to identify rhythm strips. The idea, of course, is that you will eventually internalize all this and no longer need to use the printed out algorithm anymore. It's a crutch, don't get too attached to it, but it's there for you to use, and it's a pretty helpful tool, I think. So, in conclusion, I would like you to remember that hearts are really, really cool. They're made of meat, and they do weird stuff sometimes, but they try every moment of your life and then some to keep a rhythm going, to keep blood circulating so that all your tissues are perfused, and that's pretty awesome. The other thing to remember is that they are made of meat and they don't really follow rules very well, so they do what they want. Does anyone have any questions? Any questions? All right. Thank you very much for listening, and we'll reconvene in a few minutes.